Welcome to Medical Matters Weekly with Dr. Trey Dobson, presented by Southwestern Vermont Healthcare and Catamount Access Television.
Welcome, everyone. Today is May 25th, 2022. It's actually a gorgeous day in New England. If you're outside of New England, I'm not sure what the weather is, but it's beautiful. We have a live show today. I'm Trey Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth Health. And this is Medical Matters Weekly, a show about the aspects of healthcare that matter to you most. My guest today is Dr. Amber Bonato, the director of the Dartmouth Institute for Health Policy and Clinical Practice. So first off, Amber, welcome. And again, as I said earlier, I'm so excited to have you on the show today.
Well, thank you so much for having me. I'm delighted to be here, although I do have to admit I'm feeling a little sad today. I'm sure that you, as an emergency medicine physician, and the rest of us in the country are thinking about the gun violence and the deaths of 19 children in Uvalde, Texas today. And it breaks my heart.
Absolutely, and I appreciate you bringing that up. It's sort of been the start of almost every meeting that we've had here locally, and I'm sure in most of the country, as our hearts are with those families, and hopefully that we can make some movement after this to really limit what's unnecessary, completely unnecessary struggles that we continue to see in this country, actually escalating. And maybe we can talk about that at length another time, or in addition. That's a great intro. So let me just say a little bit to the audience about Amber. She is a lot of things. I'm not going to read all of the entire bio, but the distinguished professor, so is it John Winberg Distinguished Professor at the Geisel School of Medicine at Dartmouth, board certified in preventive medicine and public health with advanced training in palliative care, and earned her bachelor's degree from the University of California at Berkeley, medical degree at Harvard Medical School, and master's in public health from the University of California at Berkeley, as well as a master's of science from Stanford. That must have taken you a couple of years, Amber, to get through.
Well, if you know anything about California, going to Stanford and Berkeley, which are, devoted enemies through football, not to mention academics, it has created an interesting aspect to my biography.
Hey, it's just you're just diversified in your background, right? That's great. Well, tell us a little bit about where you're from and any past events that sort of led you into medicine.
Yeah, that's a good question. I've lost track a little bit of that thread. I remember it feeling very present in my early career. I was motivated in a very random way. Like, I was one of those kids who was really good in school and in science, and I wanted to do something hard that would help people. And so I chose quite arbitrarily at age 8 that I thought I would want to become a doctor. Ultimately, I lost my father from non-Hodgkin's lymphoma when I was 11, almost 12. And so that sort of began to seep into my narrative about why I wanted to be a doctor, was somehow this idea that, cancer had taken the young life of my father. But I think that was more of an ex post rationalization that I provided as my sort of young adult person, as I was framing things like application essays and such as we do going to college and medical school. But the thing that got me excited in medicine, like the first thing that got me really excited was public health. I spent a year between college and medical school at the Office of Disease Prevention and Health Promotion, which is part of the Department of Health and Human Services in Washington, D.C. And that was the organization that put out the first U.S. Preventive Services Task Force Guide to Clinical Preventive Services. Healthy People, we were doing Healthy People 2000, because we were coming up on the Healthy People 1990 goals and assessing where we were. Now we have Healthy People 2030. And it was just a really exciting and heady time in Washington to be thinking about, moving the needle on issues related to public health. And I got excited about that. Was like the thing that really got me motivated and launched my career in a way that felt more authentic than that little 8-year-old who made something up, and then the 12-year-old who then, thought that having a dad who died of cancer was the reason I was going into medicine, because that was at that time completely arbitrary and part of that sort of personal sort of self-identity formation. But I didn't get excited about the field until I got into public health.
Why don't you tell the audience real quick, what public health means, especially like what it means to you. I believe many people had never even heard the term public health until actually the pandemic sort of brought it to the forefront. But of course, we've had public health and preventative health services way before COVID-19.
Yeah, I mean, I think of public health as being, there's a lot of talk about the kind of the linkages between medical care delivery and public health delivery. So public health delivery, clinical care delivery is part of that, right? But public health is broader than that. And that includes all of the kinds of protections that are in place related to regulation, clean water, clean air, personal protections like regulations requiring seatbelts, so it's a very broad construct. And of course, all the aspects of public health law that govern the management of what we're in right now, a public health disaster in a pandemic due to an infectious disease. And so the thing that excites me about it is that clinical care delivery is, I'm sure as an emergency physician, you experience this a lot. You're sort of dealing with the tragedies as they arrive one by one. And those are, there's this kind of there's a connection to human suffering and an ability to serve, which is gratifying. But at the same time, when you step back and think, wow, that automobile accident could have been prevented, or that, as we're talking about, that episode of gun violence could have been prevented if we had had some kind of broader regulatory framework, or if we had had if this person had had an intervention earlier in their mental health crisis or in their substance use disorder, for example, in the case of automobile fatality. So I think that the thing that is exciting about it as a community, as we should think about it, is that it tries to capture problems upstream of them happening. It's prevention. It's the events that could have been avoided and which avoid that loss of life and suffering that so many of us have been experiencing through COVID.
Right, you did such a great job. Thank you. And I knew you would at describing preventative health for the audience. And it's can be broken in, as you noted, to many subcategories, whether that's environmental health, occupational, and exposure. When you talked about the emergency department, you remind me of something. I often am giving presentations, and I mentioned that there are so many patients I see in the emergency department who really didn't need to be there. And the first thing most everyone thinks is that's because they had a sprained ankle or an ingrown toenail that really could have been managed elsewhere. And that's not what I'm talking about. I am talking about the gun violence victim. I am talking about the individual with severe substance abuse, that better preventative health, a better focus on preventative health, more research dollars, more effort from not only academic organizations and the government, but even communities towards these initiatives. That's what would limit people coming into the emergency department. And once they hear that, they say, oh, I see what you mean, because I'll take care of, minor or major injuries all day. It's the ones that are preventative that I wish I had more of an influence directly in the emergency department on. No. We do try to educate people on the way out and so forth, but I'm so glad you brought that up. You are a health science researcher, which is a great term. I don't even know if that's how you refer to yourself, but that's what I have in my notes here. What does that mean to you? And so you can explain it to others who may not be familiar with that term.
Yeah, so health services research, services are basically healthcare delivery, right? And so when I say I'm a health services researcher, it means I study the delivery of health services, and often through a couple of different ways. One is looking at literally the bills that are submitted on behalf of Medicare beneficiaries or other commercial insurers, and they kind of create these huge databases that allow us to look over time at the receipt of healthcare services. And then we look for patterns. One of the biggest areas of interest of mine is in patterns of healthcare use at the end of life for patients who have serious illness. So, you can look geographically and find two hospitals in the same state in the same healthcare system that seem to be more or less likely to deliver life support for people who are older and near the end of life for really unclear reasons. And so another part of my research involves, this is all part of health services research, is trying to understand those patterns that we see in the data. So I do research that involves shadowing physicians in their clinical environments and kind of trying to understand what's behind the medical decisions that they're making. One of the biggest explanatory factors that have been used for years about why one hospital might practice one way and another hospital might practice another way is, our patients are different. They're sicker or they have different preferences.
Right.
But my research has shown that it's more complicated than that. Patients construct or create their preferences based on what their doctors talk to them about, what kind of treatment options are broached, and in what order the treatment options are broached. And so, I've learned that a lot of what we see in terms of the patterns of healthcare are actually driven by physicians and in some ways, some of their unconscious thought patterns, we call those implicit, and that those get reproduced in an entire organization in a way because people start thinking similarly. They make similar assumptions about the patients who come in based on their past decisions. And so that's my area of interest. And it's really been around trying to refocus. I mean, my ultimate kind of moral and ethical goal is to refocus on the patient and the family. What are their goals and values? How can we meet those goals and values, and what's medically achievable? And that's really, of course, just in the context of clinical care delivery. We just talked about all these other public health issues. But with regard to any individual decision, particularly for patients who are near the end of life, I think there's a lot that we can do better as clinicians. And one of the things we can do is by starting with asking the patients what their goals or values are before we start talking about treatment options.
This is wonderful. I can't wait to have you back on or talk to you offline, because this is a passion I have too. Everything from Atul Gawandhi's initial look at echocardiograms down in Texas, and why are so many people getting echocardiograms. And it's not that there was nefarious actions being done by individual physicians. They were simply practicing in the way that others around them were practicing. It perpetuates the situation to all of a sudden the quote standard, which it really is a misnomer, becomes doing these studies. And that happens in the emergency department so often. And in fact, sometimes if you try to buck that trend, you're met with resistance, not only from, sometimes from your colleagues, sometimes from staff, sometimes from the patients, because, their response is, well, the last time we were in here, they did X, Y, Z. And so you really have to look at it from studying individual behavior, but then making it regional changes so that everyone can follow those. But of course, there's different specifics. And you actually were talking primarily about end of life, which is a whole other subject that can be, or at least I find it's at times more difficult to talk about because I stumble into a situation where all of a sudden someone is saying, are you trying to ration care? And of course, that's not the answer. We're trying to give the best care possible, the right care. And so it sounds like that's what a lot of your research is on.
It has been, yeah. And so if would love to talk more about that at some point.
Yeah, great. Talk to us a little bit about the Dartmouth Atlas of Healthcare. What is the Dartmouth Atlas, and how much is it used? I know it's used nationally, but maybe you could explain that to the audience.
Yeah, sure. The Dartmouth Atlas, you think about that as being like a map, right? And so that's exactly what it is. So back in the 1970s initially, Dr. Jack Wenberg, who was then employed by the state of Vermont as a public health officer, did a regional study looking at rates of tonsillectomy, getting back to this question that we were just talking about with regard to variation in practice patterns. And he found that, two different communities right next to each other, one had a high rate of tonsillectomies and the other had a low rate of tonsillectomies. And the only explanation he could find was really the enthusiasm for tonsillectomies by the ear, nose, and throat doctors in the community, right? And so this sort of started a broad focus on this concept of medical care epidemiology, studying patterns of healthcare by region. We talked about two communities in that Vermont study, but The Dartmouth Atlas is a representation of the entire United States, broken up into 306 what are called hospital referral regions. And basically there's a description of like, what is the healthcare use in that region and how does it compare to the healthcare use next door and across the country? And that's driven our understanding, similar to that Tool Gawande article that you described, of these huge variations, places like McAllen, Texas, or Miami, Florida, and some places in the country have very high rates of healthcare spending for Medicare beneficiaries compared to other parts of the country, like Minneapolis, Minnesota, have very low rates of healthcare spending. And that's even after you adjust for age. And so the question is, why is that? And so that's led, that the first publication of the first atlas, I think, was in 1996. We now have an online version of the Dartmouth Atlas. People can download data for their region or their own hospitals that they go to compare them to one another regarding different measures of healthcare treatment intensity. And this has all been relevant because a lot of the research that we've done here at Dartmouth has demonstrated that if you compare those places that use more healthcare to those that use less healthcare, even if you adjust for the relative, let's say, illness burden in those areas, it appears that more healthcare doesn't necessarily lead to more health. And that, in fact, it's inefficient. So the Dartmouth Atlas has historically looked at this level of inefficiency. It's also had kind of an equity lens to it. One of the concerns here is that if we're talking about Medicare, everyone across the country is paying the same Medicare taxes, right? We're all paying. But if I'm living in Minnesota, I'm paying the same taxes and I'm not using very much healthcare, but my brethren down in Florida are. So they're basically taking money out of my pocket and using it for their echocardiograms down there in Florida or Texas, right? And so the question is, well, hold on, that's not fair. It's like exporting taxpayer money. We agree that it's fair to shift healthcare from the healthy to the sicker. That's the whole purpose of insurance, but not based on Floridians' appetite for more echocardiograms. That's not fair. So there's been an equity angle, but largely thinking about the equity with regard to kind of healthcare spending and taxation. I think a bigger issue that I've become passionate about is this idea of, well, it also means that there are probably some people who are not getting the kind of healthcare that they need. And I think this is particularly important for communities of color who may not feel safe in healthcare spaces. They may not present to their doctors because they don't trust they don't find their healthcare systems trustworthy. They may delay care. And so they're not getting the same optimal Medicare treatment that they could get if they felt comfortable going to their healthcare facilities. And so I think that there's a problem both with overuse and potentially underuse. And that's what the Dartmouth Atlas has been focused on for really almost 30 years now.
And so that atlas, like you, just to say it again, it's available for researchers to download. They don't have to pay for it. They can get the data and use it.
Yeah, it downloads right in Excel spreadsheets. All of the code that's used to create it is freely available on a place called Dataverse. A lot of this has been funded by the Robert Wood Johnson Foundation and the National Institutes of Health and other funding agencies. And we recently looked this up. I mean, there have been like hundreds of thousands of downloads of the data. And if you actually do a PubMed search of the number of articles that have used the data, it's I think that when I last looked, it was, again, much greater than like 30,000. It was just like a 30 years worth of data use. And so it's a real privilege to be at Dartmouth, to be in a place that's informed so much research in the area of healthcare services, healthcare delivery, and more recently, health equity.
I just want to remind the audience, we're talking about variation in practice along regions. That's what the Atlas does. And just to be careful that we're not talking about necessarily variation between individual providers of healthcare with some malintent. This is developing regional practices that over time can balloon, actually, as Dr. Bernardo mentioned, not only with too many studies being done, but potentially too few studies. We're trying to reduce that variation, come up with something that's within one standard deviation or so, and not on those extremes. She referenced that Medicare costs vary around the country, almost at some points 2 to 1 in some of these states. And by putting this information out there and having that transparency, that is a one way, not only way, to start reeling in the costs and really looking at what's the most appropriate care that can be delivered. So again, you can talk to your physician about this, your advanced practice provider. It's good subjects, but don't think that individual people are making such extreme decisions without understanding that we're talking about regional variation. There, of course, is individual variation, but that's on a different level. As I mentioned from my emergency department experiences, you noted, Dr. Bernardo, the implicit bias and unconscious biases, and we actually talked about bias in several episodes. Have you seen these biases affect the likelihood that a doctor will initiate advanced care planning?
Well, I think this is a strong area of interest for many of us, is that there's this kind of chicken and egg business. Let's say if you're talking about historically marginalized groups like African Americans. As a group, African Americans over the age of 65 are less likely to have an advanced care plan in place. So an advanced directive or some other kind of living will than a same-aged white person with Medicare. And so the question becomes, well, where does that come from? Why is it? Okay. And so I have done some research to suggest that it is a mutually reinforcing cycle where clinicians see African American patients and there's complex intercultural dynamics, they're already feeling a little less at ease because it's potentially a racially discordant encounter, say with a white clinician and a Black patient. So they're already hyper aware of the discordance. And so and I've done simulation studies on this where basically without even noticing they're doing it, they stand further away from the patient. They're less likely to touch the patient. They're less likely to look at the patient or smile at the patient or to make small talk with the patient. Others have done this research as well. And so if you have a doctor who's standing a little bit closer to the door and not making as much eye contact with you, you might not feel very comfortable having a conversation about end-of-life care. That may be on the patient side. On the doctor side, the doctor may not broach the topic of end-of-life because they have in their head a recollection or a bias or a stereotype about Black patients not wanting to talk about end-of-life, that Black patients are mistrustful. And so you end up with this mutually reinforcing cycle of the doctors assuming that the patients don't trust them, the patients noticing that the doctor seems a little bit standoffish, and so they don't trust them. And so if you don't have trust, you can't have a conversation about advanced care planning. And so that's, I think, what happens there. I don't think it's that, again, we've done research to show that Medicare beneficiaries from historically marginalized groups do not have systematically different preferences for end-of-life care if they're known to have a terminal condition. The majority of both Black, white, and Hispanic patients don't want to be put on life support if they have a terminal cancer and only have, let's say, a week to live. We've demonstrated that in national surveys. But there is still a significant difference in the care that Black Medicare beneficiaries receive when compared to white Medicare beneficiaries. Black Medicare beneficiaries are much more likely to end up dying with life support. And so there's definitely implicit bias by the physician about whether or not to approach these topics. And when they see a patient who is very sick, they may assume that they want more treatment than they actually do, and they don't actually build the trust and rapport to have that conversation. So it's pretty complex. And again, it's not with malintent, I don't think. I think these are really complex, racially discordant intercultural communication encounters that are layered on individuals' own histories. People often talk about historical events influencing the trustworthiness of our healthcare system. But I think most historically marginalized patients, Black patients, Hispanic patients, particularly those who don't speak English, have had their own personal bad experiences with the healthcare delivery system. They have their own reasons to mistrust the healthcare delivery system, even independent of past abuses by the healthcare and public health system, such as Tuskegee.
Right. Which is an example used often, and is actually a great illustration of why those mistrust continues today. And there's also the lack of familiarity among individuals and groups, and that lack of familiarity breeds more mistrust as well. So that's the bias. Thank you. You did a great job of explaining the bias. Let's talk about then your thoughts on shared decision making and how that factors into some of these discussions.
Yeah, I mean, I think we talked a little bit at the beginning about my interest in end of life care, which should be goals. Any medical care should be focused on people's goals and values. I think of shared decision making. Shared decision making has evolved over time. I think when it was first introduced, it was very much introduced through the lens of decision aids. This idea that if you just empowered patients with more information about the risks, benefits, and alternatives for treating their condition, and then help them to think about what their values are, whether they valued, let's say in the case of, cancer therapy, trading off a risk of recurrence with a change in their body, for example, with mastectomy versus lumpectomy. The idea has been really about empowering patients to understand that information, right? And if they just understood the information, they would do a better job. And so these decision aids and other kinds of things were introduced. I think that the field of patient decision aids continues to thrive. There's continuing to be the development of these decision aids, which are these tools. But I think that we're beginning to appreciate more that there's affective or emotional aspects of decision making that aren't taken into consideration if you just think of an informational exchange model. And so I think shared decision making is now evolving a little bit more to understand about this, what we would call the non-rational aspects of human decision making, paying attention to the ways in which people might have intuitive senses of what their decision should be. We just talked about implicit decisions as being somewhat negative, this idea that I might have a stereotype or a bias that introduces, that influences my decisions. There's also some work that's evolving in trying to understand that idea of the gut feeling, right? If you're a patient and you have a gut feeling about a choice, A or B, there is some evidence to suggest that affective knowledge is actually potentially, if you bring that together with a more rational or deliberative approach, bringing those two things together, you get a better decision than if you just do rational decision making alone. So I think the area of shared decision making is evolving. It's this idea of, bringing together the expertise of the patient in their goals and values with the expertise of the doctor in terms of knowing treatment alternatives and, what are the likelihoods that anyone will produce a particular outcome, and then deliberating together about how to move forward. But it shouldn't just be an isolated information exchange. And this is this part where the physician really needs, or the clinician, advanced practice provider needs to be supportive. Tell me more about, I'm noticing you're leaning towards this. Tell me more about that, right? Rather than just trying to be an automaton and doing some sort of calculation in terms of risk, benefits, and alternatives. So I think that that's the place where, as a palliative care provider, I have come to appreciate that we are really in a journey with our patients, right? We're sort of there with them as consultants, helping them deliberate. And so shared decision-making is now a kind of a process of partnering with patients to make the best decision for them with the information available, and to provide them with the emotional support that's necessary as they kind of work through the anxiety associated with uncertainty, right? Because no matter what they choose, there's always going to be a certain amount of stochastic or uncertain, uncontrollable things that happen. And it's our job to provide reassurance that they're making the best decision they can with the information available.
Boy, you articulate that so well. Shared decision making really came about as a popular term in practice shortly after I started practicing. So it's really been with me for my entire practice. And the way it started out, or at least the way it got implemented, I should say, quickly became problematic because the doctor would just come in and say, okay, you can do choice A. Here's the data, choice B. Tell me what you want. In fact, let me give you a few minutes. I'm going to step out of the room and I'll come back and you tell me what you want. And people were like, what? I came here to see you. I came to hear from you as well. So, and it's still an art, though. I will say I will master it. And the day I master it is the day I have to retire, because every encounter, almost every encounter, certainly every week of practice, you learn a little bit more. You learn about how people respond, what's the best way to help them through the decision making. And I'm actually glad the term hasn't morphed into something else, because I think the term is right. It was just our initial application was a little bit off, and that's okay. So tell us a little bit about, as we kind of wrap up here, you talked about shaking up healthcare delivery. What would that look like to you?
Well, it's, that's a really good question. I was, as the director of the Dartmouth Institute, I speak with our development office sometimes about seeking philanthropic support for things like endowments. And endowments, the goal of an endowment is you get a big investment of money, which generates interest, and you use the interest on the money to fund programs, for example. And the philanthropy, the framework we were discussing the other day was how to describe a program of endowment funding that will still be relevant in 100 years, studying, health policy and clinical practice. And it stumped me, because I was thinking, in 100 years, we're not even going to have hospitals anymore. We're not going to have, I have this vision in my mind about a future in which so much of healthcare is delivered outside of walls, right? Sort of digital self-management, that there's going to be a much greater symmetry between, I hope, the patient, AKA the consumer of healthcare, the person who actually manages their own chronic disease management, their own health, and the physicians and clinical practice providers. They'll sort of be on a little bit more of an even playing field. That the patient will have more autonomy, more self-efficacy. They'll be the people who are in charge, and they're basically going to be using the clinical care experts as consultants in some ways to sort of manage their own health and well-being through a lot of, remote monitoring, telehealth. There'll be a real, I think, flattening of the hierarchy between the patient and the provider. And I do think that some of these brick and mortar places will no longer be necessary. I mean, I don't know. What do you think?
Right. I think that it's good to consider what are the options for 5 years from now and 100 years from now. And we don't know. What we do know is society hopefully matures. I call it the maturation of society in our level of thinking. And the research that you and your colleagues are doing are really helping that. It's just implementing that type of research to things, particularly at the end of life. As you mentioned, most people, certainly even in healthcare, when they do the surveys of healthcare professionals, what do you want at the end of life? It's so much more minimal than what we deliver today. And people immediately jump to, so we're wasting all that money. Well, yes, maybe that is a part of it for sure, as a financial, but there's so many other aspects where we could be using that money or that attention towards the preventative stuff that we talked about at the beginning of the show. And that's really resource allocation. What are you looking for personally and professionally as we wrap this up over the next year?
What I'm looking forward to personally is that my husband and I are helping my daughter with her college search.
Oh, wow. Great. Having just gone through that,
I am most looking forward to her finding a place that she loves and beginning to kind of enter that pathway of finding her passion in life. She's right now very interested in child development and child welfare. And so I'm really excited for watching her blossom and to practice the art of being more of a hands-off parent. So that's something I'm looking forward to. And as far as professionally, what I'm most looking forward to professionally, we have recruited several terrific faculty members in the last year. And I am looking forward to each of them. Dr. Elise Acre, Dr. Terry Lewinson, Dr. Christine Gunn, and Dr. Alka Dev totally hitting their stride and getting their first grants and just watching their careers bloom. That's what I'm most looking forward to professionally.
Oh, that's fantastic. Well, thank you so much for being on our show today.
It was my pleasure. Thank you so much for having me.
I'd also like to thank Mike Cutler from CAT TV, Ray Smith from Southwestern Vermont Healthcare, Ashley Jowett from Southwestern Vermont Healthcare. I'm Trey Dobson. Go out and find joy in everything you do, even in the face of adversity, and we will see you next week.